Thank you. Can you show me that first slide before my talk? I know this is a blurry slide, but I want you to know that one man can change medicine. One man can make a difference in the world. This is Alan Mintz, and you are all sitting here, and I am all, there you go, and I am standing here because he made a cognitive decision in 1997 that medicine needed to have a shift, that we could no longer be about treating disease, and that our sole purpose, or one of our purposes in medicine, is to allow those who are embedded in the disease-oriented system to do their job extremely well, but to design a new branch of medicine. And he was the one who coined the term age management. The AMMG, which is this body of physicians and healthcare professionals, is a direct result of that conscious decision. Now, you're sitting there, and some of you are, most of you, how many of you still have active practices? Raise your hand. So the majority of people in the room still have active practices. And out of that group that has active practices, how many do exclusively age management medicine or some form of age management medicine? I can only see about 10 hands, maybe 12. So out of this organization, there are 10 or 12 people who practice age management medicine exclusively. And I can remember in 2004, or maybe it was 3, I was asked to give a talk to the AMMG group in Fort Lauderdale, Florida. I live in Boca Raton half the time, in Vegas half the time. So I was given a talk to the group in Fort Lauderdale, Florida, and I promise you, these two tables would not, there were fewer people than there were at those two tables. We have grown by 50 or 60% every single 6 months. So this conference goes on again in 6 months in Florida, and then we have one in November again in Boca Raton. But the reason we're here is because medicine needs to change. And I, for one, really want to thank you for being here, because while he had the vision, you're the ones that are going to make it happen. Medicine, as we know it, will have to go through a major revision. And you're the ones that are going to make that revision occur. Those of us that have been doing it for 10 or 12 years, you know, we know what we do is fun. You haven't discovered it yet. This is the reason you went to medical school. This is the reason you're here. And you're here because you want to treat your patients in a better way. Okay, you can put on my first slide now. How many people in this room use growth hormone? Again, a dozen, maybe 10. So most of you, even the ones who are practicing age management, know very little about growth hormone, because what you know about growth hormone is what the media has told you about growth hormone. So what I want to do today is leave you with two things. I want to leave you with knowing a little bit about adult growth hormone deficiency, because when you see the signs and symptoms, you're going to go home and you're going to question how many people you see all the time that are adult growth hormone deficient. And yet, it's one of those treatments that is restricted from the medical care system for two reasons. Number one, the Endocrinology Society doesn't really want to accept the fact that a deficiency or an insufficiency creates enough chronic debility to treat it, because it's really not a disease. It's really an insufficiency. But look at, you heard Neil Rosier's talk earlier today. you learned one thing, I hope, and that is you can't look at TSH and T4. You've got to look at T3. There are 50% of the people that you see with minor thyroid deficiencies are T3 deficient, and yet we treat them with Synthroid. And I'm sure there are endocrinologists in the room who use Synthroid, and I'm not saying you shouldn't. I'm just saying there's a better way when you understand that insufficiency is just as important as a disease. Insufficiency creates disease. So when Alan coined the term age management medicine, his purpose was to change the way you age, to change the way we deal with chronic illnesses, to prevent heart disease, strokes, the debility of the aging process. Because here's a flash for you. Ready? You're all going to croak. And we're not going to stop it. We don't even know that we're going to prolong your life with age management medicine. But what we do know is we're going to prolong the productive way you live. You don't age without work and not develop chronic illnesses. You've got to eat right. You've got to exercise right. You heard Mickey Barber talk today about adrenal problems. Most of you have no concept of what an adrenal insufficiency is, because unless the adrenal gland shuts down, there's no knowledge of how cortisol is affecting the other hormones. So what I want you to walk away from here is a little bit of knowledge about growth hormone and maybe a little bit of passion about bringing this to modern day medicine so that physicians are not afraid to treat patients with a deficiency of a hormone that may be responsible for many of the causes of mortality in the aged population. And I'm going to talk briefly about growth hormone. I'm not going to go into detail about it, but I will tell you this. In 1999, when I became interested in hormone optimization, I had already been doing exercise and nutrition and supplements and all of the things related to lifestyle change, but I didn't know much about hormone optimization other than progesterone and estrogen in women and testosterone. But growth hormone at the time in the late 90s was still in its early phase. So in the early days, we used a lot of growth hormone in the age management business. Probably 40 or 50% of our patients we felt were deficient in growth hormone. And then things changed. And I'll show you what changed. But most importantly, what happened is we lost the concept that this is adult growth hormone deficiency. And today, we need to learn how to diagnose it. So you're going to leave here with two things. One, that there is actually a deficiency of growth hormone that has a chronic, debilitating effect on the aging process. And two, how do you make the diagnosis of growth hormone deficiency in 2011 according to what we're required to do in order to safely use growth hormone so that the medical board is not chastising you for not making the proper diagnosis. So those two things, if that's all you get out of this, my job's done. Did I turn it off, or what did I do here? Okay, so the Society of Endocrinology describes the consequences of adult growth hormone deficiency. Look at this, as decreased energy levels. Well, as people age, don't they always talk about decreasing their energy? Isolation, social isolation, depressed moods, lack of positive well-being, and increased anxiety. These are the symptoms of this deficiency. Now, I don't know about you, but there's an awful lot of people walking around, and there's a lot of people in this room that you could probably plug into 3 or 4 of them, or maybe all of them, where you've experienced something like this, and you're wondering, what the heck happened to my energy level? Why am I feeling the way I am? I don't have anything wrong with my heart. I don't have anything wrong with, I don't have a disease. I just feel like crap. I don't feel good when I wake up in the morning. I don't have the same drive. I can't compete anymore. I don't have the ability to get up and go on a 50-mile ride with 20-year-olds or 30-year-olds. Why is that? Now, I'm not blaming growth hormone as the only reason, but this is what the Endocrine Society defines as deficiency of growth hormone. And these are some of the clinical features. Wow, increased body fat, particularly central obesity, decreased muscle mass, decreased bone density. Now, I mean, right there you've got sarcopenia, you've got one of the major predictors of cardiovascular disease, and you have the risk of fractures. The number one cause of debility in people over the age of 70 in the United States is, I'm listening, a fall. A fractured bone is the number one cause of debility in the United States. It then leads to the cascade. They get into the hospital, they throw a clot to their coronary artery, they have a stroke, they get pneumonia, all because they didn't have the strength to stand on one leg. When they tripped over the step, they fell and broke their hip. And their bones were brittle, so it broke. Increased LDL, ApoB, decreased HDL. Wow, these are certainly things we know about, but it's not a disease, believe me. It's just the deficiency. Decreased cardiac muscle mass, especially if their growth hormone has been deficient for a long time. So childhood growth hormone deficiency, we don't have any question recognizing that they're going to develop cardiac disease. But in adults, we don't want them to have that because we think the growth hormone is about increasing Barry Bonds' home runs. And it's not. We've gotten a bad rap. So these are the clinical features: impaired cardiac function, decreased total and extracellular fluid. In other words, you lose the elasticity of your skin. Any of you recognize that one? Decreased insulin sensitivity and increased prevalence of impaired glucose tolerance. It's across the board. It's epidemic in the United States. We now call it metabolic syndrome. We used to call it Syndrome X. It used to not be recognized as a precursor to disease. 10, 15 years ago, you didn't even know the name. When we were talking about Syndrome X in 1980, you guys, not you guys, but the people who are determining how medicine is practiced were running us out of the state because we were a bunch of quacks. And when we got involved in growth hormone, it was the same thing. Increased concentration of fibrinogen, plasma fibrinogen, and plasminogen, activating factor type 1. Any of you got any concept about what the number one cause of death in cardiac disease is? Is it cardiovascular obstructive disease, or is it this thing called inflammation and clot? Let me think. Most of the deaths occur because of clot and inflammation. So if my plasminogen levels are out of whack and I can fix that, can I reduce the risk of sudden death from coronary disease and then accelerate? This is the Endocrine Society. This isn't our definition. These are the things you see in growth hormone deficiency. Low IGF-1 levels, and we'll qualify that in a minute. Beck depression index that's abnormal, fatigue, metabolic syndrome, truncal and visceral obesity, decreased bone mineral density, decreased muscle strength, increased muscle wasting, androgenism, decreased energy and vitality. Come on. Why do we want to wait until this is a disease? Why do, Alan Mintz used to argue with the endocrinologist, and he would say to them, this is a great one, when my IGF-1 level is 150, do I have adult growth hormone deficiency? And most of the endocrinologists at that time, this is in the late 90s, early 2000s, would say absolutely, you have growth hormone deficiency. If your IGF-1 level is that low at the age of 60, you have growth hormone deficiency. And you say, well, if I have growth hormone deficiency, I have all these symptoms, what level do you bring my growth hormone to? And they would always answer 300 to 400. I bring my IGF-1 level up to 300 to 400. And Alan would say, really? So why are those poor people who have an IGF-1 level of 200, why do they have to wait until they're so insufficient in growth hormone, until their bones are demineralized, until they're depressed, before you treat them? Why don't you treat them and bring everybody's IGF-1 level up to 300? And none of them could give them a good answer. None of them. So, abnormal fasting glucose, depression, obstructive sleep apnea. You mean to tell me that growth hormone may reduce some of the sleep apnea that we see? Yeah, it may also increase it, but there's evidence that some of these signs and symptoms are associated with growth hormone deficiency. Growth hormone is metabolized. First of all, using the word hormone for growth hormone, everybody thinks it's an anabolic steroid. It isn't. It's a polypeptide. It's produced in the pituitary gland, and it's cyclical. And there are many cycles of growth hormone throughout the day. You heard Dr. Barber talk about how you could stimulate growth hormone production with resistance exercise and anaerobic, where the resistance exercise increases growth hormone production more at higher levels than aerobic exercise. So we've changed things as time goes on, because as we begin to age, we begin to realize that if the number one debility in the United States is a fall, then shouldn't we be working on strength? And I think anyone who's ever been involved in exercise knows that you need to do resistance training, and that seems to have a better effect on your hormone levels, whether it be testosterone or growth hormone, because it asks the pituitary and it asks the testicles or the adrenal glands in women to produce more of that hormone. So this polypeptide growth hormone is metabolized in the liver into a circulating substance that seems to be fairly stable, called insulin growth factor 1. So IGF-1 is the end product of growth hormone. And for years and years and years, we concentrated on IGF-1 levels as a predictor of growth hormone deficiency. But as with everything in medicine, things change. In the early days of measuring IGF-1 levels, we did antibody assays and immunoassays. Today, a lot of labs are measuring IGF-1 with mass spectrophotometry. Now, why is that important? Because I don't really know how to tell you what level, and I'm going to show you cases today, what level of IGF-1 to call deficient. And in the European Society of Endocrinology, who, by the way, believes that adult growth hormone deficiency is a real treatable entity, in the European Endocrine Society, they say over the age of 60, you cannot rely on an IGF-1 level to predict growth hormone deficiency. So as a result, we had to find a way to evaluate the effects of growth hormone. Here's a study from Rubinoff that's looked at the Framingham group and found that over a 22-year period of time, there was a 13% lower mortality in those who had IGF-1 levels that were in the upper quartile. Rancho Bernardo study, which is a community-based study, studied healthy adults over 13 years and showed for every 40 nanograms per milliliter reduction in growth hormone, in IGF-1, for every 40 nanograms per deciliter reduction in IGF-1, there was a 38% increase in overall mortality. So there is some link between IGF-1, one of the other insulin growth factors called IGF-BP3, and it appears as though if you're in the upper quartile, you have a lesser chance of all-cause mortality, because it is the elderly that has 4 to 5 times the rate of cancer, tuberculosis, herpes zoster, and pneumonia than the young population. And maybe growth hormone is in part responsible for some of it. It certainly isn't the only answer, but it's part of some of it. So what is this entity called growth hormone sufficiency? Well, in 1997, the government, the FDA, approved a growth hormone releasing hormone called sermorelin. And sermorelin, which really should be the way to stimulate, just like if we could, we would use LH to stimulate the testicles to make more testosterone. If it were commercially available, we use HCG to stimulate the testicles to make more testosterone. So anytime we can stimulate an organ to make more, and sermorelin is a growth hormone releasing hormone. Unfortunately, it was never used therapeutically, but in combination with arginine, it became a way to diagnose idiopathic adult growth hormone deficiency, because the other test that was used was very difficult. It's called the insulin tolerance test, and I'm not going to go into that. But the arginine, sermorelin, or the GHRH analog with arginine seemed to be a good test that was safe and could predict adult growth hormone deficiency, and the endocrinologists were happy with this test because it was something they could do in their office. And then, oops, Sirona took it off the market. It's still available in Europe in another form, but it's not available in the United States, and it's never been used therapeutically. So warning to those who think you can use this without medical boards coming after you, compounded sermorelin is not legalized in the United States. Be careful, because there are people who believe because it is a growth hormone releasing factor, it can be used, and we have investigated this extensively, and it isn't legal to use because it was never approved for that clinical use. It was never approved for anything other than a means to identify adult growth hormone deficiency. But the arginine growth hormone releasing hormone test was an excellent test because it replaced the insulin tolerance test. It directly stimulated growth hormone. It inhibited somatostatin. The results produced a robust response, so growth hormone would be excreted from the pituitary. And when Sirona withdrew it, the only test left was the insulin tolerance test. Why is that a problem? It's difficult for the endocrinologist to do it in their office. It creates severe hypoglycemia. It can create seizure disorders. And there have been deaths reported from the insulin tolerance test. So here you got a relatively healthy person that you think is growth hormone deficient, and there's a mortality associated with finding out whether they're growth hormone deficient. Raise your hand, how many want that test? So as a result, the endocrinologist did begin to look for an alternative, and over time, they realized that there were risks of coronary events. The severe hypoglycemia in most patients was not well tolerated, so they had to do it in a hospital setting. And so as a result, adult growth hormone deficiency was in a vacuum. There was no way to diagnose it. And at the same time that Sirona took the sermorelin off the market, the drug companies producing growth hormone put it into the insert. In order for you to identify adult growth hormone deficiency, you must do a stimulation test. So now the drug companies were putting us in medicine at risk, saying you have to do this, but there was no test other than the insulin tolerance test. So as a result, people began to look at the glucagon stimulation test. And that's the purpose. So point number one was to point out there may be a real entity called growth hormone deficiency, and there is a safe way to make that diagnosis. And so the glucagon stimulation test, despite the fact that it was originally identified in 1972 by Kane in glucagon-initiated human growth hormone release, it never was used as a test because insulin tolerance was the gold standard. And then the growth hormone releasing factor arginine test replaced it, or at least became a safe way. So the glucagon stimulation test, despite its early detection in the 70s, was never really used in clinical medicine until around 2005, 2006. And now I think if there are endocrinologists in the room, I'm sure that some of them do this test. So we, as an age management organization, began to look at, can you establish this safely in an office practice? because we had no experience with it, and we couldn't find any endocrinologist that would help us identify adult growth hormone deficiency, and we knew it was an active part of age management medicine. So we wanted to find out, can you use IGF-1 levels? Can you do this test safely? So while it needs a little further validation, because the arginine somorelin test was shown to not only stimulate growth hormone, but also ACTH, so you could identify adrenal insufficiency and growth hormone deficiency. While there's some preliminary evidence, the glucagon stimulation test is very similar to that. We don't have enough validation to say you can identify adrenal insufficiency. And if you remember what Dr. Barber said, that's an important part of the age management practice, because cortisol is a major factor in disease. It's a major factor in hormone regulation. And yet we in medicine don't really know what to do with relative adrenal insufficiency. So if this test could identify the adrenal insufficient patient, it would be not only identifying growth hormone deficiency, but also adrenal insufficiency. Glucagon is readily available, and it's simple to perform. We've done 30 studies now, and I'm going to show them to you. We've done 30 healthy people in an age management practice, all done in the office, all in with us being totally inexperienced in this evaluation. And in your syllabus, I've put these things. Number one, it's relatively inexpensive. It costs between $80 and $130 for a milligram of glucagon. Number two, the only contraindications are you can't do it in a malnourished patient, and you can't do it in anyone who has not eaten in 48 hours. It causes severe hypoglycemia. So you shouldn't fast them for 2 days before you do a glucagon stimulation test. They should be NPO for at least 8 hours before you do the test, preferably 10 or 12, just like any other blood test. They come into the office and they're kept quiet for the entire test, except to get up to go to the restroom. They're put in a quiet room. And we have identified that you can do this test safely and identify growth hormone deficiency in 3 hours. There's still debate about whether you need to extend it to 4 hours, and I'll show you some studies that show you can, but most of the studies now say that growth hormone is usually elevated between 90 minutes, 120, 150, and 180 minutes. If you don't see the increase in growth hormone in that time, then you may get a little bit you may eke out 1 or 2 more, but for the most part, if you don't produce growth hormone in that period of time, you're probably clinically growth hormone deficient. Hypoglycemia is uncommon. We've had 0 complications of doing the glucagon stimulation test in 30 patients. The mechanism of growth hormone secretion really isn't known. No one knows whether it has to do with the stimulation of growth hormone releasing factor or whether it has to do with changes in blood sugar. All we know is that glucagon does stimulate the production of growth hormone from the pituitary gland. Usually the blood sugar rises to above 90 and then it falls slowly, but it's not precipitous. You rarely see hypoglycemia. Glucagon in growth hormone that's produced according to the Endocrinology Society, and I have questions about this, has to be about 3 micrograms per liter at any point in time during that test. So it's a very low production of growth hormone, and when I show you some normal tests, you'll see 3 micrograms. So some of the endocrinologists are beginning to think that maybe 5 is a cutoff as opposed to 3. We've kind of come to the conclusion that 3.5 is probably, an in-between. 3.5 is the number we use most of the time. It's well tolerated in adults in a large number of patients. It's accurate, it's reliable, it's available, and we've shown it's reproducible. We've done it on the same patient on separate days and gotten almost identical results as long as you use the right dose of, and also, so it's available, reproducible, and SAGE. Either that means you have to sage them before you do it, or it's misspelled and it's supposed to be safe. So I'm not sure which one it is. I'm thinking safe may be the word, but it could be sage, and then you just ohm them into existence. There's no influence of BMI, gender, or a hypothalamic cause of growth hormone deficiency. You may be able to differentiate between adrenal deficiency and sufficiency. And just another note that the growth hormone, releasing hormone, is available in Europe. So if you hear European physicians talk about using Simorulin, or it's not called Simorulin, I don't know what it's called there, but using it to stimulate growth hormone production for adult growth hormone deficiency, we would like to suggest that one of the drug companies get on the bandwagon. But why isn't it used? Why isn't a drug company picking it up? Because growth hormone has such a bad reputation, and because adult growth hormone deficiency isn't recognized in medicine, very much like the last 20 years of telling all the endocrinologists about T3, they've ignored it. And as a result, we can't really, there doesn't seem to be any company, any pharmaceutical company that wants to delve into making growth hormone releasing factor. So instead, we're stuck with using growth hormone. How much growth hormone do you use? It's higher in women than it is in men. Starting dose is usually around 7 or 8 units. There's 3 units per milligram, just the conversion factor. So 7 or 8 units is an average dose a week. A week. And for women, it's probably higher. Women seem to require more growth hormone to get an effect. And for women, it's usually around 8 to 12 units a week. Because you do need to do the growth hormone release, you do need to do the study, it's important to know that you can perform it in an office practice if you're practicing age management medicine. And as I said, it's safe and reliable. The directions for how to do growth hormone, I'm not going to bore you with, but they are in your syllabus. And for anybody who wants to set this up in their office and wants to know more about it, we'll be happy to describe it. It's very simple. All you do is an injection of glucagon intramuscularly, 1 milligram for any individual under 200 pounds and 1.5 milligrams over 200 pounds. And that's the recommended dose for glucagon stimulation. Probably should be above 250. It should be 2 milligrams, but currently those are the guidelines. You can do it without an IV as long as you have a heparin lock. But in the 30 cases that we've done, we've never had to infuse glucose for hypoglycemia. So now we don't start an IV. We put in a heparin lock so that we can draw blood, and so it has a dual port so that we can take their blood samples from it simultaneously. It's also a port that if we had to, we can infuse glucose. Occasionally, supposedly, glucagon can stimulate severe hypoglycemic episodes, but most of I have yet to meet anybody who's done this test who says they've had a patient who suffered from severe hypoglycemia. I'm sure if you took a diabetic on insulin and gave him glucagon, you could probably mess him up pretty bad. However, I don't think that's the case. I would, be cautious about using it on insulin-dependent diabetics. The patient should be weighed. Their vital signs should be done. You should measure a finger stick blood sugar, and then you're going to be drawing their blood at 0. So you do a blood draw for their growth hormone and glucose at 0. We also do a cortisol level because we want to know, we're curious a lot, we want to know whether or not cortisol is affected by glucagon. So I'll show you the results of our 28 or 29 cases. And when you leave, you'll be very comfortable in looking at a test and knowing whether or not you believe this person is growth hormone deficient. We do a baseline IGF-1 on the day of their test, fasting, and we do serial glucose measurements, serial cortisol measurements, and serial growth hormone measurements simultaneously. So we do 0 blood draw 90 minutes, 120, 90 minutes, 120, 180. We use a flow sheet like this. This one, the blood samples can go up to 240 minutes. Our lab, we've did it initially at 240 minutes. We didn't find anyone after the first 5 that had growth hormone production much above the 180, and so we abandoned using this. These are studies that compare, the glucagon stimulation test and their reliability. The one that's probably the best to look at is the Leong study. There were 414 tests that were performed. They did go to 240 minutes, but as you can see, in 2003 and earlier in 1996, there were enough studies to only take the test to 180 minutes, so we've stopped the test at 180 minutes. The beauty is 3 micrograms per milliliter has both 100% specificity and sensitivity. So it's a good test. It seems very reliable. It's reproducible, reliable, safe, and 3 seems to be the number. Like I said, I think 3.5 or to 5, maybe more. But as you can see, there is some variance between specificity and sensitivity when you get the 5 microgram variance. At 3, it's 100% specific and sensitive. So 3, it's certainly a cutoff that you could safely say. I want to show you this because in 2003, there was a study in the Journal of Clinical Endocrinology and Metabolism that showed that all-cause mortality occurred in patients who were in the lower quartiles for IGF-1. Now, I mentioned earlier, one of the concerns is that IGF-1 is now being measured by mass spectrophotometry. Most of these studies were done by an immunoassay or antibody study. I cannot tell you what normal IGF-1s are today versus where they were here. But if you just use the upper quartiles and say people with higher growth hormone levels above, who are above the mean, 1 standard deviation or 2 standard deviation above the mean, seem to have less risk of disease than those. So even with the mass spec, once we get that median for age, we can then say this is a low IGF-1, this is a high IGF-1. But today I can't really tell you what that is, and I'll show you in our cases how IGF-1 was not a predictor of growth hormone deficiency. All right, here's the first case. This is a 49-year-old. Is this pointer working? George, you know if this pointer's working? All right, well, hopefully you can all see this. The first column is the age at IGF-1 though. So this is a 49-year-old with an IGF-1 level of 179. The left-hand column is the finger stick glucose, but we also send blood to the lab. And this was an early test, and the nurse that was doing it hemolyzed most of the blood, so fortunately we have the finger stick glucose to rely on so we could follow that directly in the office. Cortisol levels, as you can see in this 49-year-old, were relatively low. And if this test is valid, perhaps there is some evidence that even though it's not very low, this person did not, and you'll see on future studies, this person didn't have much of a cortisol release from glucagon. 14 was the start, and it really went down to 4.9, which is a low cortisol level, as you'll see in the future. Growth hormone in this particular individual, while there wasn't a sample at 120, we repeated this study, but just so you can see, growth hormone was under 3, it was 2.1 at peak level. Does everybody see that? Any questions about that? Anybody know how this pointer works? Here's another case. This is a 78-year-old with an IGF-1 level of 97. Now, we've sort of identified that if it's below 150, you're probably adult growth hormone deficiency. So here's a 78-year-old who clearly had a good glucose response. Blood sugar went up to 140, and then it came down to 110. Cortisol level was relatively normal, 13, came down to 7.2. But their growth hormone level at 1.5 milligrams of glucagon, so the dose of glucagon is in the top right-hand column, at no point did their growth hormone level go above 3. So low IGF-1, clearly symptoms of muscle wasting, fatigue, depression, all the other metabolic symptoms, and growth hormone deficiency. I think we can safely say, and no one could argue, that this person is a candidate for growth hormone. Here's a 41-year-old with an IGF-1 level of 159. Relatively low IGF-1 level for someone 159. Blood sugar response is good. Got, blood sugar above 100 and then went down to 76. Cortisol, again, relatively low response, but look at the growth hormone response. Very low growth hormone production in a 49-year-old with an IGF-1 level of 159. So you can see that IGF-1, it's kind of like, 159 in a 49-year-old, I would expect it to be 200 to 300. So if it's below 200 in a 49-year-old, I would say it's safe to say if they have other symptoms, you may be looking at growth hormone deficiency. Now, one thing I want to give to all of you that are new to this, we never do a diagnosis of growth hormone deficiency in our clinic unless they've been placed, if they're going to be placed on testosterone, we always wait 3 months before we make the diagnosis of adult growth hormone deficiency. Because we have found, and we have a lot of experience with this, that optimizing their hormones, especially testosterone, will raise their IGF-1 level sometimes by 100 points. So testosterone has a direct effect on raising growth hormone levels. So our suggestion is, if they're androgen deficient, wait until you've seen the effect of testosterone before you start putting them on growth hormone, or before you make the diagnosis of growth hormone deficiency. 52-year-old, IGF-1 of 89, again, clearly growth hormone deficient. Highest level is 2.7, received a milligram. Maybe they could have received more. They're right at the point where you'd say, 197 pounds, maybe you should have used 1.5 milligrams. But in our experience, the extra half a milligram hasn't seemed to really affected anybody. It's either, you either got it, you're either deficient or you're not. It's pretty clear most of the time. Again, adrenal, this person, you can see, had a good cortisol response. So we're starting to think that the concept that glucagon can help you identify adrenal insufficiency is pretty good, that there's pretty good evidence that normal people produce cortisol after glucagon stimulation because of the ACTH effect. Here's a 50-year-old, low IGF-1 of 117, high blood sugar response, cortisol level, good response, growth hormone 3.2. So what are you going to do with this person? They're right on the cusp. They're 50 years old. Their IGF-1 level is 117. Are you going to tell them they're growth hormone deficient because it's 3.2? I don't think so. If they've got all the symptoms of growth hormone deficiency, just because they went up 0.2 of a microgram of growth hormone, I believe if they have the other components of the deficiency, muscle wasting, bone density's low, increased central adiposity, dyslipidemia, whose testosterone you've corrected, I think you're safe in saying this young person, 50, is certainly a candidate for growth hormone. And I believe that we could safely use growth hormone in that individual. 56-year-old, now we're getting into that gray zone, 3.6 micrograms of of growth hormone. I think we have to have a cutoff somewhere. They're probably, in the old days, with an IGF-1 level of 132 in a 56-year-old with symptoms, this person is probably growth hormone deficient. But if we're going to follow strict criteria by the stimulation test, I think you can't use growth hormone if you want to stay out of harm's way. Another patient who's 59, again, IGF-1 level 182, again, a fairly low response to growth hormone. So you can see the fluctuation of IGF-1 is everything from 79 so far to 190, and there's no real prediction of which, whether they're growth hormone deficient. So I think the test is necessary. I guess that's my point. My point is, I think the test is necessary. So we've elected to continue to do these. 49-year-old, 174, growth hormone deficient. So relatively high IGF-1 level, 174. Young, 49, high dose of glucagon, 1.5 milligrams, and yet they're growth hormone deficient. So I think, we're in a field where we have to start looking at how do we help these people. Another growth hormone deficient patient, 45 with an IGF-1 level of 102. Good glucose response. This is what I think is a normal cortisol response. This is what I think you would see in a vigorous, normal, healthy adrenal gland. You see 20, his cortisol level went up as high as 20 after the glucagon stimulation hit. Our experience has been, once if it's 15, 16, 17, 18, it seems to be a normal response to a normal cortisol response to glucagon. When it stays below 10, you may have a patient that's suffering from relative adrenal insufficiency. What do you do with it? That's a whole another lecture. Again, 151, 60-year-old, and here's the cutoff. The Endocrine Society in Europe says at the age of 60, the IGF-1 level is no longer a good predictor of growth hormone deficiency. So that there are people with IGF-1 levels of 200 that clearly do not produce growth hormone, and there are people with very low IGF-1 levels, but don't get confused. If you've got someone who is at risk for cardiovascular disease, who you suspect after optimizing their hormones that they're growth hormone deficient, it appears as though there's clear evidence that, at 151, this 60-year-old is growth hormone deficient. So I think, again, here's another one with an IGF-1 level of 48. In the old days, we wouldn't have bothered doing a glucagon stimulation test on this person. Clearly, IGF-1 level of 48 at the age of 48, we would say, my gosh, this is pretty darn low. But we did a glucagon stimulation test, and obviously growth hormone was not produced, but a good cortisol response, 17 was the peak cortisol level. So I think this is a test for that we could begin to look at for insufficiency. 56-year-old, 92 IGF-1, growth hormone deficient. Growth hormone deficient, IGF-1, 114, 48-year-old. 3.3, 41-year-old with an IGF-1 level of 49. If you're going to use the strict criteria, no. If they have signs and symptoms of adult growth hormone deficiency, you probably could use growth hormone in this individual. 40-year-old, no question that this is not a growth hormone deficient patient. IGF-1 level is only 111, but their growth hormone level was 5.1. So I think you've got to, if you're going to use the test, you've got to rely on that this person is producing enough growth hormone. This is a normal response to the glucagon test. This is how much growth hormone normal people seem to make. So the cortisol level went high, 22.9. IGF-1 level was 179. Relatively high IGF-1. We tested them anyway because the physician felt that they may be growth hormone deficient. It was a female. And look at the results. Growth hormone was 18.4. Clearly, you don't have to wonder whether they're producing growth hormone. They're clearly producing enough growth hormone. Here's another one at the age of 56, IGF-1 of 154, growth hormone 23. You don't have to, that's not a question. Here's a 3.7 with an IGF-1 of 117 in a 49-year-old This was a female. Again, the physician strongly suspected growth hormone deficiency. I believe this patient was put on growth hormone. Here's a 70-year-old with a good cortisol response. And I know this person personally because it's me, and it really irks me to tell you that I'm not growth hormone deficient, because I really want to be growth hormone deficient. I stayed off of growth hormone for 2 years just to prove that I needed it, so that there was no question how long I was off it before we did the glucagon test, and I was really upset with this. So, 67, clearly not growth hormone deficient. 124 IGF-1 level, clearly not growth hormone deficient. 232, why would we even bother to do a test on somebody with an IGF-1 level of 232? Because the physician had an index of suspicion that there were enough signs and symptoms of growth hormone deficiency, even though the IGF-1 level was high. I was the physician who decided, let's see what this growth hormone production is like. And you can see they're not it's not a clear cut, but boy, if you're only producing 4.1 micrograms of growth hormone, it's not the same as that 70-year-old that you saw 2 times ago that's producing 10 and 12 micrograms. This is a borderline to me. I think that at some point in time, we're going to retest this person and find out whether or not over time they become unable to make growth hormone. Normal test, high IGF-1, 227, normal test. Low IGF-1, normal test. Low IGF-1, normal test. And again, looking at the glucoses, good response to glucose, went up to 120, dropped down to 49. So no one can argue we got a hypoglycemic effect. And yet, they produce growth hormone, but look at the IGF-1 level. This is a 68-year-old. Again, 60 seems to be the cutoff. It's almost impossible in our experience to predict growth hormone deficiency in people over the age of 60, and that's exactly what the European Endocrine Society says. Here's one with an IGF-1 level of 62 and 54 years old, and they're not growth hormone deficient. And look at the cortisol level. So what is this person? This person needs meditation. This fits Dr. Barber's criteria for, adrenal overload. Here's a high-stressed person. And remember what she said about stress and growth hormone. It suppresses growth hormone production. So high-stressed individuals, high cortisol level, suppression of growth hormone. It's a common denominator. So in this particular case, I believe, and I think Saturday or some point in time I'm talking about the mind, body, and cardiovascular disease, I really think this person seriously, forget about all the hormones we use. If we're really going to manage the aging process in this young 54-year-old individual, we better start talking about how can we reduce the effects of stress on their life, because cardiovascular risk to me in this individual is extremely high. I would bet if we did intimal medial thickness and did some of the inflammatory markers, we're going to find somebody at high risk for cardiovascular disease, and we're going to be very, very careful about how we manage them. We're going to treat their inflammation, but we're also going to really put them into a program of relaxation, meditation, yoga, Tai Chi, something that helps this individual learn how to reduce the adrenal overload that they're experiencing from stress. This is a high-risk person, high risk. 64-year-old, low IGF-1, normal growth hormone. So these are references that I want you to look at. I think the message is clear from our perspective that The drug companies have an insert, a recommendation. It's not even a recommendation. It says, before you use growth hormone for adult growth hormone deficiency, you must do a stimulation test. It appears at this point in time a safe and reliable stimulation test is intramuscular glucagon, measuring sugar. You don't have to measure cortisol. It isn't part of the test, so if you want to reduce the cost of the test, you can certainly get away without the cortisol level. Measuring glucose, IGF-1 baseline, and growth hormone at 90 minutes, 120 and 180. And I think you have a reliable, simple test that you can do in any office setting, with or without an endocrinology consultation. I strongly suggest, if you can, as we have an endocrinologist, interpret all of your glucagon studies. But I really want to leave you with the idea that adult growth hormone deficiency is a recognizable complex of signs and symptoms that make the aged population at increased risk of chronic illnesses and all-cause mortality. If you've balanced all of their hormones and you've managed their lifestyle, and they continue to show signs of depression, fatigue, osteopenia, osteoporosis, sarcopenia, loss of muscle mass, loss of strength, God bless you, loss of strength, any of those things, I would strongly suggest that if you're not doing it, you refer them for diagnosis of adult growth hormone deficiency. And once again, I really applaud you all for being here, and I know that when you leave here, you're going to go home with a vision that you can change the world of medicine. One man brought all of you to this place, and we, as a conscious group, can change medicine so that the population that we deal with will be healthier, will reduce the risk of chronic illnesses, and I'll see you at 120 in my next triathlon. Questions? Probably not on.
Now it is. Thank you very much. It was a great presentation. Jim Devaney, a urologist from Connecticut. Clearly you were put in a position to have to demonstrate this based on the insert that you described. Is it your position or your experience that now that it's starting to demonstrate this level of sophistication in the results, one, will the payers start to recognize the testing and cover the testing? And two, will they also then pick up, when it's defined as adult onset deficiency of growth hormone, will they also pick up the cost for the growth hormone? Thank you.
I believe the answer to that question is, if we could convince the Society of Endocrinologists that there is an entity called adult, they would stand behind this. The European Society, they're clearly at a different level. Until the American Endocrinology Society gets a firm grasp on this concept that there is a insufficiency of growth hormone that leads to some of the debility of aging, I would say the answer to that is no. We're probably not going to get it covered by insurance, and it is relatively inexpensive to do, except for the labs. It winds up costing the patient around $1,000 when you take in the equipment and all the things you need. You need a comfortable chair in a room, and they need to be quiet. They can't be playing video games or answering the phone. It'd have to be they're supposed to be in a hospital, actually. The original study, they were done in a hospital and done in the morning while at rest. So ideally, you want to keep them as quiet as possible. I don't think we're going to see that change, especially what's going on with insurance-based medicine in the next 5 years, if ever, but certainly not in the next 5 years. Yes, sir. Yes.
In your experience, does it encourage the growth of cancer cells?
Excuse me?
Cancer growth.
No, absolutely no evidence. In fact, there is one thing you can do if you're worried about that story that's being told that growth hormone stimulates cancer. There's stronger evidence that low IGF-1 levels are associated with cancer. then, and growth hormone suppression is associated with cancer. The endogenous use of growth hormone in cancer patients, I can't give you the answer. If you have an indolent cancer, I do not think that we have a way to predict that it does anything to accelerating the cancer. However, in the early studies in the late 90s and 2000, if you measure IGF-1 simultaneously with IGF-BP3, if the IGF-1 level is low and the IGF-BP3 is low, and those people are at the greatest risk of cancer death. If you give them growth hormone and the IGF-BP3 comes up concomitantly with the IGF-1, there's zero incidence of cancer. If the IGF-BP3 falls while you're giving growth hormone, we made up an arbitrary decision years ago that if you see a fall in IGF-BP3 when you're using growth hormone, it's not a normal reaction, so take them off growth hormone. So in answer to your question, if you're following the ratio between IGF-1 and IGF-BP3, if IGF-1 goes up, IGF-BP3 goes up, there's no evidence that cancer is at risk. If IGF-BP3 falls, when IGF-1 goes up with the use of growth hormone, stop it. I don't know the answer in that group. Clear? So I think the ratio helps you distinguish that group. Yes, sir.
Yeah, it seems to me that there's a problem with the general concept of growth hormone deficiency in
Yes.
adulthood. And that is that you first say there's the IGF-1 above age 60 doesn't help you with the diagnosis of it, but then there's a target level you're trying to get to using
Yes.
IGF-1.
Yes.
Growth hormone deficiency, as defined by the by the stimulation test, is disease of the pituitary gland not producing growth hormone.
Correct.
A lot of aging adults produce growth hormone in the pituitary, but they don't release it.
Correct.
So, we're stuck with this package insert and what are the infinite wisdom of the FDA and our federal legislators, but really it doesn't make much sense, the whole concept of doing a stimulation test, because, you saw a person with an IGF-1 of 70,
Yes.
and they stimulate.
Yes. It doesn't
They're
make
growth
any...
hormone deficient. They're IGF-1 deficient.
I agree. The insert into the packet was what created the need for the test. Whereas in every other area of medicine, we're allowed to use clinical judgment. In this particular field or in this particular arena, I think because of the public opinion of growth hormone and because of the public opinion, we're not allowed to use our clinical judgment. I totally agree. I do not think that for most clinicians that have been doing age management medicine, they can predict who's going to be growth hormone deficient, with or without the IGF-1 level, most of the time.
Yeah, but my point, though, is that then why do the test?
Because medical legally, our attorneys are telling us the standard of care was determined by the insert into the packet. And if you're going to keep yourself legally clear, then you really need to confirm your clinical observation of growth hormone deficiency. And since that test or a test of growth hormone secretion, which may or may not be valid, but it's a test that seems to confirm your suspicion, then you're on safer grounds if you've done the stimulation test. If you don't do the stimulation test and you use growth hormone, in a private practice, it's not going to make any difference. In an organization like ours, it's going to make a huge difference because we're talking about thousands of patients. You may be talking about 100. So I would say that in most of your practices, you're not going to do a stimulation test. You're going to use clinical judgment. And if you feel that the growth hormone is a valid thing to use, you're going to use it. But in our situation, because we're such a large organization with so many different physicians, and because there's such controversy about growth hormone deficient, we're always trying to keep our standard at least as high as we can. Do we agree with it? No, we don't. I agree with you.
Thank you.
If you have a younger individual, 40s, and you do an IGF-1 level, I guess I'm looking at how would you approach a 40-some-year-old that you have clinical suspicion that they have growth hormone deficiency, would you start by getting like an IGF-1 level? As long as they're in the upper quartile, then maybe you don't consider doing the glucagon stimulation test?
So, okay, it would depend to a certain degree on whether they were male or female. That would be number one. In the female population, I probably would have a different answer than I would in the male population. Because females have such a higher incidence of osteoporosis, if I had a female in that category with osteopenia or clear osteoporosis.
And you determine that with like a bone density scale?
Yes, okay. We do bone densities on everybody. And she also had other, signs of depression or something that, quality of life score was low, and she was, lost her vigor, and all of sex libido was down. And I had already treated her estrogen, progesterone, DHEA, and hormone levels. I would definitely do a stimulation test. In the male, it's a little tougher because you don't usually get those associated symptoms until later. But if I had them, I would definitely, suspicion of growth hormone deficiency in my world says it's a 3-hour test. It's like the old glucose tolerance test. Why not do it? You're going to pick up somebody who you could really help, and you at least have protected yourself medical legally by following standard of care.
Okay, thanks.
Hi, my practice is mainly women, and
Yeah.
I've been doing IGF-1 levels on them,
Yeah.
along with all their other hormone tests. They come in symptomatic by and large, and I do hormone restoration with estrogen, testosterone, progesterone, etc.
Yeah.
Haven't been using growth hormone. I routinely see their IGF-1s go up 30 to 50% or even more over the course of a year of getting hormonally restored. Would those people benefit by using growth hormone, or how would I know if they're maximized?
I don't think so, unless they were not improving over that year. If you know your population of women, you know the things that women unfortunately suffer through in the perimenopause and menopausal phase. If you're seeing a woman who came into you who's central obesity, glucose intolerant, was a little bit, energy was low, depressed, all of those symptoms, and over the course of the year, you've corrected all of them. No, I wouldn't touch them. I would leave her alone until she showed clear signs that your therapy was not, because you're talking about relatively. If she was 65, I might, but not if she was 45.
Okay, thank you.
How frequently are you checking MRIs of the brain if there are multiple hormones off or some other clinical findings?
Great question. Great question. Never. But I believe that you brought up a great point. Anybody who you can document has had signs of trauma, any kind of trauma, even if it's a minor fall off of a bicycle, or when they were young men, they played football in college, or because there's so many people that have panhypopituitarism from trauma that anytime I can document trauma, I'm going to refer them for an MRI most of the time if I'm suspicious that there's more than just the normal. If I'm treating them and they're not getting well, I'm definitely going to. So I would say every time we see trauma, whenever we see enough trauma, and I can tell you stories of people who were in minor automobile accidents who have abnormal MRIs of their pituitary gland. So I think you definitely have to consider it. We're a little bit of mavericks in this field, and we've been doing it for a long period of time. We use a lot of clinical judgment, but I think you bring up an excellent point. I think in a solo practice, I'd probably do it a lot more than I do it now.
From your experience of using the growth hormone,
Yes.
Is there any long-term, any complications you experience?
Two. There's first of all, I can tell you we have a lot of experience with this over 14 years, and we don't use it as much now as we did in the early days, and we were pretty free with the use of growth hormone. The two symptoms that you will see, that both of which are reversible, are carpal tunnel syndrome and a swelling. It's almost indescribable. The patient will just tell you, this is the way they'll describe it. They'll say, I feel tight. And it has to do with intracellular fluid increase. Now, that being said, those two complications occur around 10% at a time. So it's a high enough complication. Other than that, the only one that we're aware of is if you have someone who is borderline metabolic syndrome, where their hemoglobin A1C is 5.9, their fasting blood sugar is 102, their mean blood sugar is 130 or 122, their triglycerides are high, and you've treated them and they're still in that phase and they have central obesity, and you use growth hormone, follow the hemoglobin A1C very carefully. If the hemoglobin A1C continues to rise despite you controlling their diet, take them off growth hormone, see if it comes down. So that's the only other one that we've experienced. And in the diabetic patient on growth hormone, you can worsen their diabetes. The other, getting into the disease population, I could give you some other information. The other one is in cardiomyopathy, occasionally because of that swelling phenomena, you'll make them worse. So don't do growth hormone unless you're experienced in cardiovascular treatment or you have a cardiologist that's following with you if they have cardiomyopathy or congestive heart failure. We did a study of congestive heart failure and growth hormone and testosterone last year in conjunction with UCLA and Dr. Ernst von Schwartz, who's here today. And our retrospective analysis said that we improved cardiac function with growth hormone and testosterone. But we didn't isolate growth hormone without testosterone. That I will say. Okay, androgen deficient individuals with congestive heart failure, we improve them with growth hormone and testosterone. Yes.
The divergence between your IGF-1 levels and your testing results with your glucagon stimulation test, I find very interesting. My question for you is:
I find it depressing.
were all of the patients who you put into your study preparing in precisely the exact fashion before coming in for the test so as not to confound their IGF-1 levels, which we know can change in response to so many different stimuli?
The answer is we did our level best to control. Our instructions were clearly that they were to not exercise the day before they came in. They were to be fasting, and they were, if we could get them in, because we have our in Boca, we have our facility at the Boca Resort. If they could come in the night before, we had them come in the night before so that they came from their hotel room to our clinic. We have a private room set up, no stimulation, no telephones, no TVs, no computers. They could get up to go to the bathroom, which is approximately 100 feet. So we did everything we could to control that factor, yes. Dietary factors as well as we could, yes. They were because most of these patients were on our program, so yes.
We're going to have to stop. I want to thank Dr. Willix